And you'd be surprised. There's a lot of moms out there kind of struggling with the same issues. And the world of difference it makes just to know that you're not alone out there, and that there are people out there you can talk to.
For decades, cardiology treated men and women as if their hearts were identical. Same symptoms, same risks, same treatment. They were wrong. Because a young woman with arrhythmia just isn't heard differently. She's often dismissed, told it's anxiety, told her heart is fine, told to come back when she's older. So what really happens when we stop ignoring the differences between men and women? When we actually listen to how inherited cardiomyopathies and channel myopathies show up and change across a woman's entire life. My guest today is Dr. Danna Spears, an electrophysiologist at the Peter Munk Cardiac Centre in Toronto. And full disclosure, she's been my doctor for over 12 years. Dr. Spears will be the first to tell you women with these conditions aren't just smaller versions of men. And the questions women ask about longevity, pregnancy, and living a full life deserve answers that actually fit. Please welcome Dr. Danna Spears. Hi, Dr. Spears, and welcome to Let's Talk SADS Live. I'm very glad that you're here with us today. You and I, full disclosure, have a patient-doctor relationship. I've been in your practice as a patient, I think it's got to be at least 12 years, at least, and receiving great care. I really appreciate you coming on today.
Oh, well, my pleasure.
So what we want to talk about today is women who are dealing with inherited cardiomyopathies or channel myopathies, and how these conditions are, uniquely happening with women. Maybe we'll give the men their own segment in another episode, but for today, we want to just concentrate on the women that you see in your practice. Just broadly or generally, do you see any big differences between men and women that you treat, or the way that you might treat them?
That's a very interesting question, actually. And I think when historically in cardiology, we have not really appreciated the difference between men and women in terms of their cardiac care and their cardiac risk and how they present with any cardiac condition, and especially the inherited arrhythmias and inherited cardiomyopathies. And I think aside from some hormonal issues that we can talk about going forward, there are a lot of differences, particularly as we're talking about family planning, body image issues, medication tolerance, and contraception. So these are things that we don't discuss as frequently in our male population, whereas women, it becomes a lot more important in terms of planning their lives and planning their families. So there certainly is a difference at all stages of life in terms of the main concerns that a patient's going to have, and how we address their risk and how we manage that.
That's interesting. So let's kind of dive in, and we talked about, we'll have this hypothetical patient named Jane. And since you see women of all ages, we'll start sort of at the beginning. Let's imagine a younger woman, maybe a late teenager, early 20s, has come to you. What sort of issues do you think she might have faced, even in terms of her own symptom recognition and maybe getting a diagnosis?
Absolutely. So when a young woman is first presenting, I think one of the first barriers in terms of healthcare, especially if she's presenting, for example, with palpitations or some, skipping heartbeats or some unusual symptoms like that they often will get brushed off and told, this is anxiety, you're worried about something non-cardiac, this is not your heart, you're low risk because you're a female, because you're a young female. There's often this assumption that their cardiac risk is very, very low, and then to always seek alternative diagnoses, often psychiatric diagnoses, rather than addressing a cardiac condition, or at least doing a good comprehensive screening evaluation for a cardiac condition. So that is, that initially is a big barrier to diagnosis for young women, because their symptoms can overlap with, for example, anxiety disorders. So that's the first one, is just being able to make a diagnosis, to get an electrocardiogram or to get a Holter monitor, rather than being, patted on the head and being told not to worry about it. Once a diagnosis is made, whether it's made on an electrocardiogram, on imaging, or even genetic testing when we're screening families for conditions, one of the first barriers is acceptance. And so sometimes these young women have very few symptoms, and we're identifying an abnormal electrocardiogram in long QT syndrome, for example, or doing family screening and identifying a genetic anomaly in an otherwise asymptomatic young woman. So first, there is the issue of accepting the fact that there is a cardiac diagnosis at play, because forming that relationship with introducing the concept and understanding their disease process and the importance of managing it, risk stratifying, and treating it, it's really important to develop that relationship with a patient, particularly when they're a young female, because this is often very new to them and not something that is openly discussed. And so, sort of being gentle with that information delivery and allowing a lot of time for questions. And questions don't often come right at the moment when you're sitting in an examining room presenting this type of information. There's often a lot of questions that come later, and it's important to be available to answer those questions and to anticipate the types of questions that are going to come. For example, as we've discussed, and we'll probably discuss this a bit later, but as a young female, for example, 18, 20, there's going to be questions about longevity. Is this going to impact how long I'm going to live? Am I going to live to be an old woman at some point? A lot of people will hear about these diagnoses and assume that they're going to have a shortened lifespan, and that's often not the case. It's usually not the case. And then to introduce thoughts about having children. Can they have children? And in most cases, absolutely they can. And to be able to address those questions and anxieties about moving through the different stages of life is an important thing to address. The third thing that I find more challenging, or something that needs a little bit more time, especially in younger patients, is discussion about medical therapy. So taking a beta blocker, for example. So in this age group, especially young women who are in their late teens and early 20s, they're often very academically involved. They're involved in sports and athletics. They're socially active, and they're very concerned about their body image and how they're going to function as a young, vibrant woman in society. And I think a lot of working together a lot with finding the right medical therapy that isn't going to cause, for example, concerns about weight gain or energy levels, and being able to address those concerns with them, and moving into more aggressive arrhythmia management, for example, having a defibrillator. That's going to be a very important intervention in a young woman in terms of her body image and how she sees herself, what clothing she can wear, how may open discussion about her condition with people she may not want to disclose that to, because a defibrillator can be, it's not the most subtle intervention in our young patients. And so having conversations about that and listening to what's important to them in terms of their body image and social image is also important in arriving at a treatment plan that's acceptable to both of you, to keep her safe, but also in a way that she feels that she's part of the decision making, and that the impact that it's having on her life is her choice, and she understands the rationale for it, I think is really important. And that takes some time to build that relationship so that you can work together to manage these conditions.
Yeah, you really touched on the, self-acceptance of this condition, and also the reality of it. I mean, when you talk to a young woman about the placement of the ICD, which, mine is just above my pec on the left-hand side, but above the breast. I mean, if you wear a halter top or a bikini top, it's exposed. You can see this. Yes. Are you showing them where it's placed? Like, how do you help them get over that hurdle?
Yeah, so there's a few things that we do. Obviously, the anatomic discussion about placing a transvenous defibrillator on the chest wall, or a subcutaneous defibrillator, which is a bit of a larger device, but it fits under the arm, so it's not as visible, with different necklines and bathing suits and whatnot. However, that will also have important implications for the type of underwear that they can wear and how this is going to be visible, because it's a bit of a bulkier device on the side of their body. And so being able to show them photographs of what it's going to look like. There are really important support groups through SADS, for example, where people are able to connect with other individuals who have this type of device. And I think I have found that my young female patients are very receptive to this, and they really appreciate having that community where they can ask questions, talk to other young women about where they had their device placed, the experience, any complications that happened, things they need to think about or look for after having a defibrillator in either location. I think that for these young people, the social milieu of finding other people who are similar to you with similar concerns is the importance of that is really underestimated, I think. And young patients value this so much, just to feel like they're not alone and to have someone to sort of commiserate with about their diagnosis and their experience, and realize that I'd like to think that most people realize it's not quite as catastrophic as they originally think, and most people end up living very full lives with this. And it's nice for young women to hear that from people who've been through it.
You might have had to advise some patients to stop exercise or stop competitive sports.
Yeah.
But then weight management and good health then becomes an issue. How do you have those conversations, and what do you typically advise young?
It's very interesting, Heather, because this actually, the data around obesity and cardiac health we've always known that there's benefit to weight loss and that there are downsides to obesity. But in the last 5 years, our understanding of the relationship between obesity, heart function, and arrhythmias has exploded. And in these genetic disorders and in young people, they're underrepresented currently in the research. So we have to do a lot of extrapolation of data and cardiac outcomes from populations, for example, with obesity and diabetes, or obesity and coronary artery disease, or other causes of heart disease. But something that is entering the conversation a lot more frequently is the impact of body weight and obesity on both heart function as well as on cardiac arrhythmias. And arrhythmias, surprisingly, are very, very sensitive to excess body weight. So we have found, for example, when you think about obesity, you have a higher risk of sleep apnea, of hypertension, of glucose intolerance, of general inflammation. All of these things can worsen arrhythmia burden. And it's been shown in well-established literature that, for example, atrial fibrillation, the burden and incidence of atrial fibrillation can be dropped substantially by almost 40% with about a 10% body weight loss. And so, atrial fibrillation is one arrhythmia that's quite common in the inherited cardiomyopathies. And so I think managing obesity is becoming an important tool that we have to try to minimize the arrhythmia burden on these populations. And so I think it's a very important conversation to have, to really engage in weight management and diet and safe exercise from an early age, because missing that boat and allowing weight to become out of control in these young patients can be disastrous, and it can make their entire clinical experience that much worse.
So there's treatments now for obesity, the GLP-1s that we've heard about, like Wegovy and Ozempic. How do they fit into your practice?
So these medications right now, unfortunately, they're approved for managing patients with diabetes. So something that I'm finding frustrating is we have patients who are struggling with their weight. They're on beta blockers, so they don't feel well when they exercise to, their full capacity. They're restricted from exercising to their full capacity. So weight becomes a really important issue. And we always, we have all the conventional advice to watch your diet and to try to walk more, for example. But let's be fair, that doesn't work for most people. So what I find frustrating is we have these GLP-1 inhibitors that are so strong at reducing cardiovascular endpoints in obesity and in obese patients with diabetes, but trying to get access to these in a cost-effective way, especially for our young Canadian patients, is a challenge. However, there are an exciting new tool that we have to manage obesity and improve cardiac outcomes. So the GLP-1 inhibitors, some important things are that, for example, in long QT syndrome, they've undergone rigorous QT studies to ensure that they do not cause QT prolongation in and of themselves. So that is a very helpful finding for our young long QT patients, that taking one of these medications is not going to put them at increased risk specifically from a drug effect on the heart. In the genetic cardiomyopathies, we also know that these GLP-1 inhibitors do not cause adverse events, so they don't have any negative impact on heart function. The data is a bit too weak right now to prove that managing the obesity is going to improve heart function. So we can't be calling this an intervention that's going to treat the heart failure, but certainly treating the hypertension and sleep apnea and getting the weight down is going to improve all of those parameters that drive heart function. The only thing that I'm very cautious about with the GLP-1 inhibitors in the genetic cardiomyopathy populations, and especially the long QT populations, is that there can be significant nausea, vomiting, and diarrhea with these medications, especially in the early days or at higher doses. So with that can come low potassium and low magnesium. And we know that both of these things prolong the QT interval, but can also be pro-arrhythmic, for example, in ARVC. And so, managing low potassium and low magnesium becomes very important in these when using these medications. So that's important counseling, to make sure to flag this information to your doctor if you can't keep food down and you're vomiting and not able to keep electrolytes in, because then reduction of the dose to the lowest manageable dose is going to be important to avoid pro-arrhythmic situations. But otherwise, I think these are incredibly important tools now, as long as there's a discussion about the potential GI risks, for example, with these medications. But so far, they're the most effective tool that we have for reducing body weight with excellent outcome parameters in heart disease.
Well, I just can't help but think what a difference that would have made in my life in my 20s and 30s and 40s, just really struggling with weight after being a competitive athlete, then having to really curtail that and not being able to use, exercise as a way to help keep weight down. It's a losing battle. It's tough. So
absolutely. No, I'm really excited about where these are going. I mean, obviously with caution and some concern about some of the adverse effects, but for weight loss and reducing cardiovascular adverse outcomes, so far they've been a very strong signal for use.
That's great. Let's move our patient forward a little bit. We'll age her very quickly. The magic of the podcast. We're going to age Jane Doe into her years where she would like to now start maybe family planning. Yeah. This has been I think a huge positive change in that. When I was in my young 20s, I was told there was no possibility with my condition ARVC to get pregnant or carry a child. So, lots of great things have changed for Jane Doe. So tell me about the considerations that go into, fertility treatment, carrying the child, labor and delivery, all the way through postpartum and breastfeeding. And I do want to just say to our audience that you have done a very deep dive into this in an earlier episode that people can find on our SADS Let's Talk Live YouTube channel. So if someone wants to get really down into the nitty gritty, you've supplied that information, but I'm kind of speeding up Jane's age and asking you to sort of encapsulate some of the considerations you take to manage a woman who'd like to get pregnant with these conditions.
Sounds good. And so then just touching on, we've kind of talked about obesity just very recently, and I think that this is another important signal that's evolving is the treatment of obesity and improving fertility. So that's another important discussion is, in terms of fertility, keeping weight management under good control. And the GLP-1 inhibitors can obviously be useful for that. The GLP-1 inhibitors cannot be used in pregnancy, though. And it's important to recognize that there's a washout period that is recommended, at least 35 days up to, most practitioners will do 2 to 3 months of washout before a pregnancy. However, there has been no animal signal of any teratogenicity or major developmental anomalies with the use of GLP-1 inhibitors. So it's not recommended. For example, if a woman is taking one and then finds herself pregnant, you simply just stop it. And there's been no signal that there's an increase in fetal malformations. But just in general, we do like to stop them and not have them in the system. So that's, one optimizing for fertility. In terms of avoiding pregnancy, there are very few contraindications to having a pregnancy. And so those are really severe heart failure, so severely depressed ejection fraction, women with uncontrolled arrhythmia. Obviously, this is something that you want to get under good control prior to a pregnancy, but we can manage successful pregnancies with defibrillators and beta blockers. And some antiarrhythmics can be safe in pregnancy. And so that's an important conversation to have with your doctor when you are family planning. Having a good understanding of your genetics, because this will be helpful for conversations around prenatal diagnosis or cord blood testing at the time of delivery, so that child can have some genetic anticipation of what their childhood and what kind of screening and cardiac testing is going to be required in childhood. So that's an important consideration for a young woman to know that she can use this information in terms of planning and managing her pregnancy and delivery. It's also very important, there's a common misconception about beta blockers. So I get referred a lot of women with inherited cardiomyopathies or channelopathies who have discontinued their medications in anticipation of becoming pregnant. It's really important that we communicate to young women that these beta blockers, the majority of the ones that are being used clinically now, are safe in pregnancy and in fact can reduce adverse events in pregnancy. So the women that we see run into trouble are women, for example, with ARVC who have well-controlled ventricular arrhythmia on a beta blocker who then stop their beta blocker. There's strong evidence that those women are more likely to have arrhythmia events during their pregnancy. So maintaining stability before pregnancy and then into and through pregnancy is really important. So, please have conversations with your doctor before you're making changes to any of your medications. Having a defibrillator or a pacemaker is something that we manage routinely through pregnancy. We've even implanted defibrillators and pacemakers during pregnancy if arrhythmias become an issue during pregnancy, which is extremely, extremely rare. In terms of other, have we moved into hormone replacement, or now we're just at pregnancy right now?
Still at pregnancy. Is there considerations for delivery? I think you touched on cesarean deliveries. That might be a special consideration.
Yeah, so some women choose to have a cesarean section for personal and non-medical reasons, and that's their decision. But in terms of medically indicating that a woman needs to have a cesarean section rather than a vaginal delivery, that's also incredibly rare. So women with severe heart failure, sometimes we will recommend cesarean delivery, as well as women with very dilated aorta. That's a situation where we don't want a woman to go in and push through labor and delivery. And some severe valvular disease, we don't want to have go through natural delivery, but those aren't really those are rarely implicated in the genetic cardiomyopathy or arrhythmia conditions. So the vast majority of women can safely have a spontaneous vaginal delivery, and the vast majority will also deliver without cardiac telemetry. So telemetry is where you go through labor and delivery wearing almost like a Holter monitor, where you have the leads all over you and a small box that transmits your heart rhythm live to someone who's watching this, every minute of the hour, to ensure that no arrhythmias are observed. And really, the only time I recommend that is for women who have already have very frequent arrhythmias, non-sustained ventricular tachycardia, women who have unexplained syncope, where there's a very arrhythmic sounding etiology for their fainting. Otherwise, cardiac telemetry is not absolutely necessary, and many women deliver at their local hospitals and close to home with their family. And so that's something that is a consideration just for high-risk women to have telemetry monitoring during labor and delivery.
And is it safe for these women who are on a beta blocker to be breastfeeding for the child?
Yeah, so most of the beta blockers are safe in pregnancy and breastfeeding. There are certain beta blockers that actually tend to concentrate more in the breast milk, so they tend to be a bit more of a concern. Sotalol is one of them, because sotalol is renally excreted, so from the kidneys, and oftentimes very, very young newborns don't have perfect kidney filtration at the time of birth. And so if they're being breastfed with a mom who's been taking sotalol, they're actually going to get a good amount of sotalol in the breast milk, which may not be adequately renally cleared. And so I generally recommend that women on sotalol be very cautious with breastfeeding or supplement with formula, so that the neonate is not getting a full diet of breast milk with sotalol, or watching the electrocardiogram very carefully, the baby's electrocardiogram, because sotalol can cause QT prolongation. The other beta blocker that we use frequently in very high-risk arrhythmias and in women with long QT syndrome is nadolol. Now, nadolol has been shown to be safe in pregnancy with no increased risk of lower birth weight or hypoglycemia, for example. But nadolol is another beta blocker that is more concentrated in the breast milk, and again, is predominantly renally cleared by the newborn. And so at the usual doses that I'm using to manage arrhythmias or women with long QT syndrome, it's not an issue. But at very high doses, so when you're getting into 120 or 160 milligrams of nadolol, that's something that concerns me a little bit more. And not to stop or switch the beta blocker or stop breastfeeding, but just to monitor baby's heart rate and blood glucose a little bit better, especially in the very early days when their kidneys aren't working as well. But absolutely breastfeeding. Again, there are very, very few reasons why I would recommend someone not breastfeed, and using sotalol or, for example, amiodarone or some drugs may lead to that recommendation, but in most cases, no. Most cases, it's fine to breastfeed.
And is there any consideration for the number of births that a woman might like to have? I mean, no. Is it one and done, or?
No, absolutely not. And so for, the one condition I worry about the most, or in theory you would worry about the most in pregnancy, is ARVC. And there have been some very elegant Scandinavian studies of multiple pregnancies in ARVC, where they've looked at women who have had no pregnancies, one pregnancy, or multiple. And there is no difference in the change in their electrical parameters, so their ECG findings or arrhythmia, or structural parameters, so that it doesn't make the right ventricle any more weak or dilated to have 0, 1, or multiple pregnancies. Then another interesting thing that they looked at was many years after pregnancy. So they wanted to see, sure, you have 3 pregnancies, in your 30s, what happens when you're in your 50s? And again, they've shown that these women don't have any worsening of morphologic changes or electrical changes over time after having multiple pregnancies. And so if you're a woman with well-controlled arrhythmia, if you don't have severe heart failure going into it, because that's a bit of a different story, but most women with ARVC have good left ventricular function and reasonable right ventricular function. I have no concerns about multiple pregnancies over many years. There's no indication that there's any worsening of heart function with that.
That's great news. Well, let's take our Jane Doe now, post childbirth years. Let's move her into her menopausal years. That for some women can be 40 and onwards.
Yeah.
What special considerations are now given to women in this age group?
So in this age group, we start worrying about the things that affect all men and women as they start to get older. So we start looking at obesity, we start looking at their blood pressure, we start looking at cholesterol and blood glucose parameters. So even though someone has a very rare genetic cardiac condition, they're still vulnerable to all of the most common cardiac complications that happen to us as we get older. So it's important to, shift the focus a little bit, because now that you've survived into your 40s, 50s, 60s with these conditions, you're generally considered to be much lower risk, basically because of your survival bias. So now we have to start thinking about managing all of these other atherosclerotic risk factors. A question that comes up very frequently is hormone replacement therapy. And times have changed so much since the Women's Health Initiative decades ago, where there seemed to be a greater signal for cardiac complications and breast cancer, for example. Now, the form of hormones that we use have changed, both the types of estrogen and the types of progesterone that are used in hormone replacement therapy. They're completely different. And so now the recommendations are for, if a woman is, under the age of 60 and less than 10 years from menopause, they have the greatest benefit from hormone replacement therapy now. The benefits are less if they're started, more than a decade after menopause has started, or in women who have already reached, 70, 80, then the benefits are going to be less. The cardiac benefits are still soft. So we're not seeing strong cardiac benefits with hormone replacement therapy, but we are seeing, for example, reduced central obesity with estrogen exposure. We're also seeing improvements in cholesterol parameters, but they have important impacts on vasomotor symptoms, energy levels, overall sense of well-being, bone density. So these are important conversations to have with these patients. Now, I would like to be able to say that they're going to improve your cardiac parameters, but not necessarily at this time. But there's certainly no reason to avoid hormone replacement therapy in these conditions. The one exception is long QT syndrome, where exposure to unopposed estrogen can actually cause QT prolongation. So in women with long QT syndrome, we're very careful to always use a combined hormone replacement therapy, where we're giving bioidentical progesterone as well as bioidentical estrogens. Now, there is some signal that the very earlier progesterone formulations, which were more androgenic, so had more male hormone features, actually shortened the QT interval, particularly on exposure to QT prolonging drugs. So there's an important signal for progesterone to be improving the repolarization parameters in these women. So I always be very cautious to always use progesterone in addition to estrogen in long QT syndrome. But for women with the inherited cardiomyopathies, absolutely hormone replacement is not going to put them at increased risk for arrhythmias or adverse events. This is talking about the general population. So I have to also say here that this is a very evidence-poor area. And so this conversation is more, anecdotal and extrapolating the general data to ARVC and hypertrophic cardiomyopathy populations, for example. But there's been no signal for adverse events. And if anything, they can improve quality of life and a lot of the vasomotor symptoms associated with menopause. So I have no concerns with discussing the use of HRT in these conditions.
Great. That's good. It's good news. Well, in conclusion, we just want to wrap it up. You've talked a lot about the physical management, the physical symptoms through a life stage for a woman, but is there any special advice that you give women in your practice, just managing from a mental health or well-being that you could share with us today, just as a takeaway? Women are often the ones in the home that are, they have a job, they're taking after the children, they may be looking after elderly parents, in addition to work and other commitments. I mean, it can be a heavy burden, these diseases. Do you have any final thoughts on that you could speak to women about?
Yeah, and I think that's an important part of most of the young women that I'm managing. That's an important part of their identity. They want to be a busy mom. They want to be active in their career and at work, despite medical appointments and symptoms and the use of beta blockade. And I think it's really important to try to support them through maintaining this identity of a vibrant, active woman through all the stages of their lives, and not trying to over medicalize them. And I think that something that and I'll say it again, has been so underappreciated, is the importance of community. So there's so many times where a woman feels, raising kids or having a career or, whatever they're doing in their life, that they're alone, and that they're managing this alone, and that they don't have supports. And I think that SADS has been so important in creating this environment where you are able to have these discussions and ask questions and get support from others, because you think you're the only busy mom out there with a defibrillator, on a beta blocker, with one of these inherited heart conditions. And you'd be surprised, there's a lot of moms out there kind of struggling with the same issues. And the world of difference it makes just to know that you're not alone out there, and that there are people out there you can talk to share these ideas, can make such a huge difference in how they manage their medical condition.
Well, that's great. I think that really hits upon what we're trying to do here, is create community, share information, help people get supported, and know that they have good resources like you to help them through this. Awesome. Thank you so much, Dr. Spears, for your time today.
It's my pleasure.
Really appreciate it.
Thank you for having me.